Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. I'm Dr. Shameen, ER consultant from King Saud Medical City. Today I'm back again with you with another video presentation regarding one of the most hot topics in the emergency medicine. With me for this topic, to have a little bit of discussion about this topic, I have with me my two colleagues. One is Dr. Nader.
Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Dr. Nader Bukhari. I am a Saudi Board of Emergency Medicine R4 resident from Security Forces Hospital.
Thank you very much, Dr. Nader. And my other colleague with me today is Dr. Muhammad.
Assalamu alaikum, I'm Dr. Muhammad Al-Bawi. I'm in Saudi Board of Emergency R4.
Thank you very much, Muhammad and Nader. So, Dr. Nader and Dr. Muhammad, as you already heard me saying that today we are talking about airway, and we'll start our discussion with the airway assessment. Regarding the management part of the airway, we won't be taking it today because we want to split this airway topic into a couple of sessions. Let's focus today only on the airway assessment. As you know, that airway forms the bread and butter for the emergentologist. It's one of the most important and the critical issues with anesthesiologists, and it forms one of the most important aspects of the topic in the management of patients with critical care physicians also. So, when I'm talking about the airway, it has been reported in the literature that failed airway or difficulty in establishing an airway in an emergency department in non-traumatic patients counts to around 0.5 to 0.7% of the patients, which is really very less. And when it comes to the traumatic patients, it comes around to 1.5% patient or 1.7% of the patients who have a failed airway in the ED. So when we say airway management, actually basically we are managing the airway because of three important aspects. The first aspect because of which we are managing the airway is that whether the patient is able to protect the airway or not. This is the first important thing, which is very important, which makes us to think of airway protection. In addition to that, whether he is able to protect his airway or he is handling his secretions. Second important aspect because of which, as you guys know, that we are managing or maintaining the airway is that is the patient having any problem with ventilation and breathing or not. This is second important step. Third important aspect of the criteria which makes us to decide about airway management is anticipating a bad outcome or anticipating the worsening of the condition of the patient. These are the three grossly broader aspects which make us to understand that we should do something for the airway management. So I'll start my discussion with Dr. Nader. Dr. Nader, could you just enlighten the viewers why is airway assessment very important?
Sure, sir. Thank you. So in order to have a successful airway entry or access to the patient, such as ETT intubation, we have to assess the patient properly. And this assessment, it's gathered in a mnemonic called LIM. So this lemon stands for L. Let's start with L. Is by looking and eyeballing on the patient, on the face of the patient, and assess just quick assessment by the eye. How the airway is look like. Can the patient, is there any trauma in the mouth? Is there any trauma in the nose? Patient is secreting a lot from the mouth, or what is going on? So next is E. Stands for evaluation, and this evaluation stands for constitute of 3 steps. This 3 steps is called the 3-3-3-2 rule. Now let's start with the first 3 rule is to put the examiner hand 3 fingers on the mouth of the patient in order to measure the opening of the mouth of the patient from the beginning of the incisor to the upper and lower incisors. If it is fitting 3 fingers, that means there is a good access for airway, so this is an easy intubation. If it is less than 3 fingers, that means it's difficult intubation. The second 3 rule is to put 3 fingers between from the momentum of the jaw of the patient up to the higher bone. It's supposed to fit 3 fingers. If it fits less than 3 fingers, that means it might indicate for a difficult intubation. The third step, last step, is to put 2 fingers between the higher bone and the thyroid cartilage. Okay? If it is less than that, 2 fingers, that means it might indicate also for a difficult intubation. So this is for E evaluation. Going back, now going next to the M, limb. M is Malapati score. we have 4 scores, from 1 to 4. 1, if you open the mouth of the patient by the pressure and you look, you can see everything. This is score 1. Score 4 is you are not seeing nothing. You see nothing except the tongue.
Okay.
So in between, you can judge 2 and 3. And of course, 4 is might also indicate for difficult, definitely indicate for difficult intubation.
Okay.
O stands for either obesity or obstruction. So obesity, patient might have short neck, cannot fit mask, or cannot actually insert the tube because of this short neck. So you have to have a proper sizing for the tube, and so on. Obstruction, again, patient cannot move the neck, it's obstructing, anything obstructing the foreign body or whatever.
Like for example, he has a huge tongue macroglossi, or he has any abscess or any connection in the floor of the oral cavity, like Lubin's angina, or maybe a submandibular space infection. So that's causing obstruction, and you cannot place in the tube further. This is what exactly you want to say.
Yes.
Okay.
Thank you.
Yes. Okay.
And lastly is N. So N stands for neck stiffness.
Okay.
As you all know, we have to manipulate the patient sometimes for a proper visualization of the airway, the neck, and we have to move the neck properly in order to have a successful intubation. Sometimes patients, you might have neck rigidity, or elderly patient, they might have stiffness in the neck, so we cannot
Manipulate the neck in the proper position. Fair enough. This is perfect. So, Dr. Nader, you were talking about the Lehman assessment of difficulty in the endoscopy in a patient who needs an airway management. So this Lehman assessment is the gestalt, the physician gestalt, which he is utilizing. Let me just re-emphasize one point here with you two guys, that all the assessment scores or all the assessment techniques which have been mentioned in our literature actually are not evidence validated quite well. Though we are using them every now and then, but they have not been so, there's not a strong validation behind all of the scores. But still they roughly guide us when we have been, exactly, when we have been ready with our different plans of management. Thank you very much, Dr. Nader, for elaborating quite well about the Lehman classification and assessment of airway when it comes to laryngoscopy. I'll start with Dr. Mohammed. Dr. Mohammed, I just want to know, so that our audience can have an idea, how can you assess the difficulty in bag mask ventilation?
As we know, as an airway, we need to have second, we need to bagging the patient, we need to assist before doing it. We have a mnemonic called as MONS.
Okay.
It's stand for M. It's for mask seal of the patient. Is the patient have a beard or have no tooth in his face? How to assist the mask seal? Is it fit for and if it's for pediatric or other different sizes, is it for
okay.
Then for the obesity and obstruction,
okay.
the same.
As Dr. Nader has already mentioned about obesity, the same.
Obesity will be difficult for bag masking.
Fair
because it can become for one size,
sure.
Either for adult or pediatric. And the adult, it's different sizes. We cannot. The next letter is A for stand for age. The elderly people become distorted anatomy, stiffness. It's difficult for them after the changing in the anatomy and
so you mean to say with the increasing age, the changes in the anatomical structures in the body, in the particular the facial configuration, makes it difficult for bag mask, making a tight seal over the patient's face.
Some of the elderly become more constricted, it cannot be mask sealed.
Fair enough. Perfect, excellent.
Then for the neck stiffness, as Dr. Nader said, with the neck stiffness, we cannot mobilizing the neck, cannot mobilizing well for the patient.
Great.
Stiffness, yeah.
Okay, next stiffness. Okay, so what do you mean to say this moves actually gives us a rough idea
about the no teeth?
Yes.
It will be difficult if the patient have teeth or no teeth.
Okay.
If there is No, better to ambobag, if not teeth, to flip the lips and put the ambobag inside.
Excellent. This is one of the techniques which has been devised by some of the airway experts, that they say once you are ambobagging an edentulous patient who doesn't have teeth at all, just flip the lower teeth, lower lip, and make a seal over the lower lip, keeping the lower lip away from the mask, from the face mask. So there's an old saying that when you have to intubate, no teeth in for intubation, full teeth in for ambobag. So what does that actually mean? That intubation becomes easier when there are no teeth at all, and ambobagging becomes easier when there are full dentures present. So this is what actually he means to say, that you can make a tight seal with a face mask only if you have the teeth present in the oral cavity. All the teeth. The patient is not edentulous. Thank you very much, Dr. Mohammed. This was the first step about endotracheal intubation difficulty. The second step was about back mask ventilation. Actually, why we are discussing this all, why we have to assess the airway and decide about various steps, because if we fail in step 1, we should have a plan B ready. We shouldn't cut a sorry figure that we already decided to go ahead with a definitive airway for the patient. Without assessing the airway, we went ahead and we found that it was a difficult airway and we didn't have any plan B ready with us. And there is a little bit of difference, as you guys will agree with me, between emergentologists, anesthesiologists, and critical care physicians. We emergentologists, our patients come unprepared to us. They come uninvited. They are not prepared, they are not assessed before they come to us. It's an emergency situation. While as when a patient is prepared for an anesthesiology, for an anesthesia or any procedure or he has already undergone a pre-anesthesia checkup and the airway assessment is done at that time. This privilege or this opportunity the emergentologists don't get at all. That's why it becomes more important for us to assess the airway in the shortest span of time we are spending with the patient, and we decide about our plan A's, plan B's, and plan C's. In other words, such plans for such methods which we are doing, we call them as double setup or triple setup. Am I right? I mean, you guys are following me. Yeah. So I have another important issue which I want the audience to know about. We have, other than ambobag, we have some extra glottic devices. So is there any mnemonic or an arbitrary method of assessing when the extra glottic device placement will become difficult? Do you have any assessment for that?
Yes, so there is a mnemonic called RODS.
Okay.
And this stands for, let's say, R is for restriction, I believe.
Yeah, restriction of opening of the oral cavity. Exactly, yes.
Because you need a good access for this laryngeal mass because of its size and all the shape.
I'm sorry to interrupt in between. Before we go ahead with the extra glottic devices, I would like you to give a little bit idea to the audience. What do we mean by extra glottic devices? What are these extra glottic devices? Just name them. What are they?
So we have extra glottic device. From its name, extra glottic device, so something that can be inserted above the glottis, above the airway.
Okay.
One of these devices is a tube called LMA, laryngeal mask airway.
Okay.
Now this has a shape of triangular shape with port of air coming out, and the tubing is as well taking the normal anatomy of the oropharynx of the patient.
Perfect.
Which helps to stabilize easy insertion and help blind insertion as well, and help to stabilize the airway entry to the patient without any difficulty or without any hesitation, and even for low experienced doctors can do it as well. So, yeah.
So, coming back to the assessment of extra glottic device difficulty in assessment. So you said there is a mnemonic called RODS. So R stands for restricted opening of the oral cavity. So we have ODS first.
Exactly. So further on, O is again going back to either like the doctor said, obstruction, obesity. That's the same thing. You need to clear the airway very well, check that there is no obstruction. D stands for distorted anatomy.
Perfect.
Now, because this tube needs to be fitted very well, so any distorted anatomy of the airway, let's say the tracheal deviation.
Sorry to interrupt you again. Distorted anatomy, it's a trauma patient, for example. So a trauma patient or upper airway trauma has a distorted anatomy, or this patient has undergone some radiation because of some oncological issues. So because of this radiation, there's a distorted anatomy. So yes.
Usually it's inserted blindly.
Yeah.
You cannot use any.
Exactly. So it's a blind insertion. So in such a situation,
if you changes, there will be difficulty.
sure. So in such a situation, when you are inserting in blindly, you have to be doubly sure that your laryngeal mask airway is going exactly in the supraglottic space. It is just snugly fitting over the aperture. And then you inflate it. So these are some of the difficulties of placing in a supraglottic device. Thank you very much, Dr. Nazir. So if we fail in putting in a supraglottic device, we failed in putting in an endotracheal intubation. So we decided about the difficulty, what were the difficulty in laryngoscopy, as you already mentioned. And then you took over the back muscle ventilation. You talked about the difficulty in back muscle ventilation. Then we came back to Dr. Nader and we talked about the extraglottic or supraglottic devices, which are other method, one of the ways of securing the airway when you cannot. One of the most important things I forgot to tell the audience here, that this extraglottic device can convert a situation of cannot intubate, cannot ventilate into cannot intubate but can ventilate. So this is one of the very important things we have to understand here. So if we cannot intubate, we cannot ventilate. And we have an idea of putting in an extraglottic device. We can change the situation into cannot intubate, but still can ventilate.
So this as a bridge.
Yes, as a bridge, still we have the other plan B or plan C ready with us. So lastly, I want to ask Dr. Mohammed, what are the difficulties in cricothyroidotomy or the surgical area, which is the final step in the airway management?
There is mnemonic called this SMART.
Okay, SMART.
The difficulty of the.
Yes, sure. Please go ahead.
SMART starts with the safety, history of safety above the thyroid cartilage or any distort in the history of surgery causing anatomy.
So any neck surgery in the anterior aspect of the neck
cannot be using.
Perfect.
And for mass effect on the thyroid cannot be do because of the thyroidectomy need the blade and insertion of the tube.
So
in the membrane. If there is any mass effect, we cannot insert any.
So, for example, there is an abscess, there is a hematoma, there is Ludwig's angina, or there is some mandibular space collection. This cannot allow us to access the cricothyroid membrane anatomically well. Yes, yeah, central thyroid enlargement, goiters. We cannot access the cricothyroid membrane through these masses. It becomes difficult for us to do a cricothyroidotomy. So, what else?
SM, then A for axis of the thyroid.
Yes.
If there is any difficulty of access to the thyroid membrane, it will be difficult for the procedure.
Perfect. So R
for the radiation, if there has to be radiation before,
Yeah.
it's difficult, fragile skin and cannot be treated easily.
So post radiation again is one of the difficulty to do a cricothyroidotomy. This will distort the anatomy. And lastly, we have
Lastly, it's either trauma or trauma or tumor.
Yes, exactly. Yes, exactly. So we have a mnemonic SMART, which has been already dealt by Dr. Mohammed quite well. So these are some of the difficulties in cricothyroidotomy or a surgical airway when the other steps fail. So this was about the assessment of the airway. Now let's talk realistically in our day-to-day clinical practice. What is actually practically possible from all these things? Yes, we do apply all of them. But having said that, you know that Mallampati classification or the Mallampati application is not clinically possible in our setting, in an emergency setting. We cannot ask the patient to sit in front of us and ask him to open his mouth and assess his air. There are some evidences or some supporting material wherein they have been using Mallampati in a supine position also. Is there any alternative method of assessing the airway other than Mallampati, which is mostly used by emergentologists?
I'm not sure about further. There must be some.
Okay. So, are you aware of any other?
Assessment by direct laryngoscope, Cormack and Lane.
Wonderful. So, a direct laryngoscopy, Cormack and Lane classification, which helps us to assess the airway by which helps us to assess the airway by doing the laryngoscopy.
So
you
two
do
classes, either 1 or 2 it will be easy.
Yes.
And 3 and 4 it will be difficult for difficult intubation.
Perfect. So this assessment is done while doing the laryngoscopy. So by and large, the Malampati or the Karmark and Lehen, they correspond to each other if you go by the classes. But the difference, there's a little bit of difference. The difference is this, that Malampati is done while the patient is awake or is sitting in front of you or is supine, while the Karmark and Lehen classification is based on laryngoscopy. There is a little there are some updates in the airway assessment, like one of the criteria which has been recently been implemented in the military warfare by the name of Heavens criteria. This is one of the criteria which is being used by emergentologists also nowadays to assess the airway. What does actually this Heavens stand for? It stands for hypoxia. So any patient in a state of hypoxia is assessed to be a difficult airway. E stands for extremes of age. They say less than 8 years, and quite extreme of age is one of the possibilities of a difficult airway. A stands for anatomical abnormalities in it. V stands for any vomitous, blood, or excretions. This is one of the difficulty. HEAVE. E stands for exsanguination, where if the patient is anemic, it is considered to be one of the possibilities of a difficult airway. Because considering the patient being anemic, the apnea time is decreased for such patients. N stands for neck mobility. So this is one of the criteria which is being implemented. Other than that, there are some updates which are there in the assessment of the airway. For example, let's talk about the Malampati. Nowadays we are using modified Malampati scoring. Previously we had Malampati scores of 3. Now the new Malampati the modified Malampati is 4 scores. Likewise, Karmark and Lehen, when it came into vogue, were only 4 classes. Class 1 to class 4 or grade 1 to grade 4. Now some of the authors or some of the clinicians are believing that there are 6 classes of Karmark and Lehen, starting from class 1 to class 2A and 2B, then 3A and 3B and 4. So basically all the airway assessment tools whichever we are talking about are not so strongly validated, and it's purely a clinical judgment or a clinical gestalt which helps us to assess and decide about the plan B and plan C about the airway of patient. Having said this all, whatever we talked about the airway assessment, one of the most important aspects which I wanted to talk about here is, or ask you people, is that there are some interventions when we decide about that the airway is in compromise. There are some interventions which we do, and one of the most important interventions, as you both guys know, is manipulating the airway. So there are 2 techniques of manipulating the airway. One is head tilt chin lift if it's a non-trauma patient, but if it's a trauma patient, we do only the jaw thrust. This is well known to us. I just want to go back to Dr. Nada and want to just ask him, when would you like to place in some devices in the patient, like for example an oropharyngeal airway? When would you like to use it in an patient of airway compromise?
Sure. So we have adjunct airways to use, and specifically if we have a patient who is comatose.
Okay.
Okay. And we usually use a device called the oropharyngeal airway,
Okay.
which is a small device that has something called the flank and bite protection, and also it's a tube that takes the shape of the normal anatomy of the oropharynx and the tongue.
Perfect.
And this in order to help support further air entry into the patient, especially that the comatose patient, they usually have a floppy tongue and
There might be a tongue fall.
Perfect.
Perfect.
And cause a further obstruction which may not even control except by this device.
Perfect. So a patient, if he is comatose, you would allow to place in an oropharyngeal airway for him. And then there is a saying, we should make it clear to our audience also, if a patient is tolerating an oropharyngeal airway, means think that patient might need an endotracheal intubation. This is one of the indirect indication that patient might require an endotracheal intubation. Yes. Because if you rely only on the gag reflex itself, it has been documented in the literature that normally in normal person the gag reflex is absent from 7 to 25%. So we cannot rely only on the gag reflex. So this is one of the indications where you should think of putting in a definitive airway with an endotracheal ventilator. Dr. Mohammed, I just wanted to come back to you. What are the indications of when you should place in a nasopharyngeal airway?
Either we have distorted anatomy,
Yes.
distorted oral anatomy, we use nasopharyngeal,
Okay.
or during stiffness of the neck, and we cannot open the mouth, we use also nasal.
Or if the patient is awake and cannot tolerate a nasopharyngeal airway, is gagging, has retching of, you are inducing vomiting, you can put in a nasopharyngeal airway, and you can maintain a patient's airway, and subsequently you can decide about bagging the patient or whatever measures you want to do for him for further management. I think we have covered most of the areas of airway assessment. Thank you very much, Dr. Nader. Thank you very much, Dr. Mohammed, for giving your valuable time in helping us to make up this video for airway management. Thanks a lot.
Thank you very much.